This conference will now be recorded.
Hello everyone. Today, inshallah, we'll discuss the management of delivery, which is important module after management of labor. And this is a module include three important green top guidelines. First, about the assisted vaginal pairs, 2020, April of 2020. And the second green top guideline is the management of shoulder dystocia. And finally, we'll discuss the management of third and fourth perineal tear. This is three important guidelines we'll discuss today in management of delivery. I hope to cover all this guideline and its related question. So let us start our session. First, we'll discuss assisted vaginal pairs, green top guideline, 26 2020. This is very important instrumental delivery. This is a very important aspect of intrapartum care because the aim of the assisted vaginal pairs is to mimic the spontaneous vertex delivery or spontaneous vaginal delivery. What about the incidence of the operative vaginal delivery in UK? So the operative vaginal delivery rate have remained stable between 10 to 13% in UK. So this is about the incidence of the operative vaginal births. It is stable between 10 to 13%. There has been a rise in rate of cesarean births in the second stage of labor. This may reflect concern about the assisted vaginal birth morbidity or loss of clinical skills. So what about the classification of assisted vaginal births? We have three major classification of assisted vaginal births. The first one is the outline assisted vaginal births. So outline assisted vaginal births at +3 station. At +3 station, that means the fetal scalp has reached the perineum and fetal scalp visible without separating the labia. And rotation in this station usually not exceed more than 45 degrees. This is the definition of outlet assisted vaginal birth. It is 3 plus station, and that is mean the fetal scalp visible without separating the labia, or the fetal scalp has reached the perineum and the rotation has not exceed more than 45% degree. What about the second classification of assisted vaginal birth? It is plus at +2 station. So that means the fetal skull is at station +2 centimeter, but not on the perineum. And these have two subdivisions, maybe non-rotational or rotational. The non-rotational is less or equal 45, and rotational is up to 45 degree. And finally, the third one is the mid cavity assisted vaginal birth. It is at station 0 and station +1. That is mean the fetal head is no more than 1/5 palpable per abdomen, or leading point of the skull is at station 0 or +1 centimeter. So they also have two subdivision, non-rotational and rotational. So how to know the classification? So we'll discuss here. If you mind this, okay, this is the pelvis, and here this is the spine. The spine a zero station. Okay, and this is plus one, and this is plus two. Please mute your mic. Please mute your mic. Okay, thank you. And this is plus, this is minus 3, and this is minus 2, and this is minus 1. And here is the plus 1 and plus 2 plus 3. And if the head is zero station, here this is the head. If the head at zero station, okay, you can, this is, imagine this is the zero station. If the head above the zero station, so this is for cesarean section, no for the assisted vaginal path. So the cut point here is the zero station. So it's above. If the UDBV and you find this is the head of the presenting part above the zero station, no role for assisted vaginal birth. So we'll do cesarean section. So in case of less than zero station and between 1 and 2, here it is between 1, 0 and plus 1. This is for mid cavity assisted vaginal path. So 0 and plus 1. So maybe rotational or no rotational. If in between is at 2 plus 2 station, this is low assisted vaginal path. If it's about 3 or it's a perineum, this is the outlet assisted vaginal path. So that is the classification of the 3 important assisted vaginal paths. So there is no role for high assisted vaginal paths. This is the new guideline, not included in the classification and not recommended as operative vaginal delivery. So only it's the outlet, low, and mid cavity. So this is the about classification of assisted vaginal birth. In summary, outlet is at plus 3 station, low is at 2 station, plus 2 station, and mid is about 0 or plus 1 station. So what is the factor reduces the need for assisted vaginal birth? So it is similar to the factor reduce cesarean section, and the most important one is the continuous support. So this is the same factor for reducing incidence of cesarean section. So the factor reducing the need for assisted vaginal delivery is the continuous support and use of upright and lateral position in the second stage of labor. And the third one is avoiding epidural analgesia or epidural regimen with reduced motor blood. Delayed pushing in malleolous women with epidural of 1 to 2 hours or until they had strong air to push. This is about the factor may reduce the need for the operative vaginal delivery, and the most important one is the continuous support, and this is the recall question. There is insufficient evidence to recommend or support the following to reduce the incidence of assisted vaginal birth. The hypothesis that discontinuing epidural analgesia, so on the other hand, is the increase the pain, and routine oxytocin augmentation for women with epidural analgesia, or routine prophylactic manual rotation of the fetal malposition in the second stage of labor. So also routine oxytocin or routine prophylactic manual rotation of fetal malposition, this is not recommended, or there is no evidence to support or to recommend it. This is factor can reduce the incidence of assisted vaginal pairs. So what is the defining assisted vaginal pairs? So device-assisted vaginal pairs use a standard classification, a system for assisted vaginal pairs to promote safe clinical practice, effective communication between health professional and audit of outcome. So what are the recommendation and the contraindication of assisted vaginal pairs? So operators should be aware that no indication is absolute and that clinical treatment is required in all situations. So there is no absolute there is no absolute indication for assisted vaginal pairs. Suspected fetal bleeding disorder or predisposition to the fracture are relative contraindication to assisted vaginal pairs. This may be relative contraindication as is fetal bleeding, suspected fetal bleeding disorder, or predisposition to fracture. These are both relative contraindication. Blood-borne viral infection in the woman are not absolute contraindication to assisted vaginal birth. So there is no absolute indication, and there is no the blood-borne viral infection is not absolute contraindication to the assisted vaginal birth. So the use of vacuum is contraindication following of the blood sample, fetal blood sample receipt or application of the fetal scalp tool. So the use of vacuum is not contraindicated after fetal blood sample or application of the fetal scalp tool. Operators should be aware that there is a higher risk of subclavian hemorrhage and scalp trauma with the vacuum extraction compared with the forceps at preterm gestational age. Vacuum births should be avoided below 32 weeks of gestation and should be used with caution between 32 and 36 weeks of gestation. This is the new recommendation 2020. So the vacuum should be avoided below 32 weeks of gestation. So preterm below 32 weeks of gestation and should be used in caution between 32 and 36 weeks of gestation. What about the contraindication for operative vaginal delivery? This is the summary. If the patient did not consent or there is lack of expertise, undetermined fetal position, unknown position, before full dilatation of the cervix and this vacuum extraction, if there is malpresentation, face and breech, and vacuum extractors, any contraindication to the maternal bushing. And vacuum extractors if the gestational age less than 32 weeks and caution between 32 and 36 weeks of gestation. This is the about summary of the contraindication of operative vaginal delivery. So what is the indication of assisted vaginal pairs? This may be fetal or maternal or combined indication. So the suspected fetal compromise, a CTG pathological abnormal fetal blood sampling result, or there is sick meconium. So this is the indication for assisted vaginal pairs in the fetal. And maternal, it may be nullibus or pulse. So in nullibus woman, the lack of continuing progress for 3 hours, so the total of active and passive second stage labor with regional analgesia, or 2 hours without regional analgesia. So if the patient have 3 hours with regional analgesia and or 2 hours without regional analgesia. So you can do, this is the indication for assisted vaginal birth. In Barres woman, lack of continuing progress for 2 hours, the total of active and passive second stage of labor with regional analgesia, or 1 hour without regional analgesia. So this is the indication of assisted vaginal birth in multivarus or Barres woman. As the other indication is maternal exhaustion or distress, if there is any medical indication to avoid valval maneuver. And combined here is the fetal and maternal indication for assisted vaginal birth often coexisted. So this is about the important indication of assisted vaginal birth. Here is the essential condition for safe assisted vaginal birth. Safe assisted vaginal birth require a careful assessment of the clinical situation, clear communication with the woman and healthcare personnel, and expertise in the chosen procedure. Here, this table is very important. Here, this is about the safety criteria for assisted vaginal birth. First, the full abdominal and vaginal examination and related to the preparation of mothers and preparation for the staff. So we'll start first with the examination and the vaginal examination, abdominal and vaginal examination. So the head is less or more equal palpable bare abdomen. In most, not palpable. In most cases, not palpable. So the head is less or equal to 1/5 palpable. The cervix should be fully dilated. So this is the prerequisite for assisted vaginal birth, and station at the level of scale of spine or below. So 0 station and +1, +2, and +3, and on the perineum. This is the indication for assisted vaginal birth. And the position of the fetus has been determined. So the position should be determined. Okay. Caput and molding is no more than moderate or +2. So what about +3? Is it possible for the assisted vaginal birth? +3. Molding +3.
No.
No, it cannot be.
Yes,
restricted.
because, excellent. Because this is suspect CBD, cephalopelvic disproportion. So this is a contraindication for assisted vaginal birth. So look for the degree of molding and the caput. And pelvic is adequate, so it's adequate pelvic. This is about full abdominal and vaginal examination. What about the mothers? There should be clear explanation given and informed consent that taken and documented in human case. Look, sorry. Okay, clear explanation given and informed consent. So consent is very important in assisted vaginal birth. Appropriate anesthesia, very important, and maternal bladder should be empty. There's also wheeling catheters and aseptic technique. This is about important preparation for mothers, and their staff should be this have experience and skill necessary, and adequate facilities are available, and backup plan for mid-pelvic birth and anticipate complication. This is about preparation for the staff. So this is the safety criteria for assisted vaginal pairs. Is it clear?
Yes, doctor.
Yes, sir.
Okay. What about the analgesia? Instrumental delivery should be classed as operative procedure that therefore carried out adequate analgesia. So NICE recommends that instrumental deliveries are carried out under tested, effective regional anesthesia. So either spinal or epidural. So the important analgesia here for the assisted operative delivery is the potential block technique. So to perform a potential block, the ischial spine must be located on the one side of the pelvis by palpated during BV. So you do BV and palpate the ischial spine. This is the first step in potential block technique. The ischial spine can be palpated at approximately a finger length into the vagina at 4 or 8 o'clock. After that, shielded needles is then introduced into the vagina between the maternal tissues and the operator hand. Approximately 8 ml of 1% lidocaine is inserted into the tissues 1 centimeter medial and 1 centimeter inferior to the ischial spine. So the process is then repeated on the contralateral side. So this picture will show how to do. So here, this is about the ischial potential block. And here, you can do ischial spine. Can palpate the ischial spine on the 4 to 8 o'clock. As you know, the potential nerve behind the sacro, this is sacrospinous limit, and the pudendal nerve is passed behind the sacrospinous ligament and is located 1 centimeter. It's medial and anteromedial and posteromedial to the ischial spine. So it's about 1 centimeter medial, anteromedial and posteromedial to ischial spine. This is about the site of injection, and the needle must be inserted into about 1 centimeter depth, and you can draw about 20 ml of 1% lidocaine. There's 2 types of needles, either needle guarded or unguarded. This is about the potential block. This is the needle. It is guarded and maybe unguarded. So what is the type of ventouse? There are different types of ventouse. For example, there is maelstrom cup, and there is cystoelastic cups, and as you know, this is the familiar to you, it's a keyway ventouse. There's 2 types of keyway ventouse. This is about the basically for the type of ventouse. Here, this is the cup, and this is the body of the ventouse of vacuum. So here the important one is the level of the pressure. It is starting from the yellows is 0.2 and raised to up to the red line here is 0.8. So this is the rapid increase of the pressure. So we'll increase the pressure to 0.2 kilogram per centimeter square. Check for maternal tissues entrapment between the cup and the fetal head, and then increase to 0.8. So if you apply the cup in the flexion point, you should, before to increase the pressure, you should to check this for maternal tissues entrapment. If no maternal tissue entrapment, you can increase the pressure up to 0.8. So recheck for any maternal tissue entrapment prior to applying traction. You again to check if there is no maternal tissue entrapment. It is acceptable practice to increase the pressure directly to 0.8 kilogram per centimeter square when using electric cup, as long as you continuously check for maternal tissue entrapment whilst increasing the pressure. This is about QA. Look for the first will start with pressure 0.2, and here is the level of the 0.8 kilogram. So what about the technique of applying ventouse and forceps? This mnemonics here as the also styles here as the A, B, C, D, E, F, T, I. So this is the mnemonic of the also. First for address. So address the patient, so explain and take consent and discuss the anesthesia and do abdominal examination to ensure 1/5 or less of the head is palpable. This is the first step in both in the ventouse or in the forceps. So A for address of the patient, B for bladder, so ensure this is the empty, and C for cervix must be fully dilated, sure adequate contraction, and this fully dilation. D for determine position and also station. So check this is station 0, station 1, station 3. So check the equipment. And flexion of point. What is the definition of flexion of point? What is the definition?
It is 3 centimeter anterior to the posterior fontanelle.
Okay, thank you, Travis. Yes, it is about 3 centimeter anterior to the posterior ventricle. Okay, this is the definition of flexion point. So flexion point is very important and very crucial landmark for the ventouse. And for the forceps, you should position for safety. This is if you want to apply for forceps, you should position for safety. And here is gentle traction after raise of the pressure 1.8 and halt. H for halt. The proceed if there is no descent with 3 contraction or if the cup pop off twice. So at what time we halt the proceed for ventouse and forceps? Anybody knows? At what time we halt the proceed for ventouse or for forceps? So here, halt. Okay.
3 pop-ups for forceps, sir.
Okay, Dr. Baglo. Yes.
For ventouse, if there is maximum of 3 pushes we give. If there is 2 pop-offs with ventouse, we halt the procedure. And with the forceps, with the 2 maximum of 3 times traction we will give. If there is failure and progressive descent with maximum gentle traction applied, then we will discontinue the procedure, sir.
Okay, thank you. Yes, you're right. Here, halt the proceed if ventouse if they have about pop off 2 times. This is before was 3 times in the previous guideline. But the new one recommendation is pop off 2 times. Or if there is no progress, the head is not become on perineum with 3 pull. If you do 3 pull without head in the perineum, you should stop the ventrous. Or 2 bob off. So 2 bob off, this is enough to stop the proceed. In case of forceps, 3 pull, following 3 pull. If birth is not imminent, so we will stop the proceed. Is it clear?
Yes, sir.
Okay. And this you should check the episiotomy, and if the jaw remove instrument in visible. This is about how to apply the ventrous and forceps. This is the flexion point. This is also the recall question asking about what is the definition of flexion point. This is the posterior ventricle and this is the anterior ventricle. It is about 3 centimeters in front of the posterior ventricle, and other definition on the other hand maybe 6 centimeters posterior to the anterior ventricle. So the definition is 3 centimeters in front of anterior ventricle. This is the how to apply the cuff in flexion of point. So here, what about the fetal problem? Here may be complicated with subclavian hemorrhage or cephalic hematoma. So how to differentiate between subclavian hemorrhage and cephalic hematoma? This is very important question, and this is the recall question. Anybody knows? So what is the difference between cephalic hematoma and subclavian hemorrhage?
Subclavian hemorrhage is small degeneration because it is under the periosteum, but cephalic hematoma is localized, controlled by the suture.
Yes, thank you, Dr. Juman. Thank you, exactly. Okay, so here, if you look here, this is the skulls. So first the scalp, and then calial abreutia, and after that we found this is the subclavian hemorrhage. So occur between above the periosteum. So if this here periosteum, above the periosteum, this is the subclavian hemorrhage, and periosteum can occur below the periosteum. This is the cephalic hematoma. So cephalic hematoma is the bleeding below the periosteum of the skull. So this is the definition of cephalic hematoma. And subclavian hemorrhage is also extracranial bleeding. So under the scalp. So can definition under the scalp, and this is the life-threatening condition. So this is the difference between subclavian hemorrhage and cephalic hematoma. And this is subclavian hemorrhage is well defined borders and may be fluctuated and maybe have fluid wave. This is the difference between subclavian hemorrhage and cephalic hematoma. Subclavian hemorrhage can be fluctuated and well defined border and may have fluid waves. So this is the recall question. Here also, this is the also. So differentiation.
Can you repeat again? Hello?
Okay.
Can you repeat
Hello?
it again?
Okay, sure.
Hello? Thank
Hello. Welcome. So you should
Dr.
know.
Fatih? Dr. Fatih, can you ask Dr. Jumana to close her camera so we can see the screen well?
Dr. Jumana?
Yeah, yes. Okay, good now. Thank you.
Okay. Okay. Here it's very important to know the difference between subclavian and cephalic hematoma. So if you want to define the subclavian hematoma, it is extracranial hemorrhage. It is below glial abreutia, and this is under the scalp. Okay, so if there's glial abreutia below there is extra cranial hemorrhage, below this scales, this is the subclavian hemorrhage. And periosteum, and if there's any bleeding below the periosteum of the skulls, this is defined as the cephal hematoma. So the difference here, it is the under scalp subclavian hemorrhage, and under the periosteum, it is cephal hematoma. So the position here is very important. And the second one here, the subclavian hematoma or subclavian hemorrhage, it is well-defined borders. So it's well-defined border and form to fluctuate and maybe have fluid wave. This is the three characteristic for the subclavian hemorrhage, and so to differentiate it from the cephal hematoma. So this is the recall question. Here you should looking for the site of the bleeding. If below the periosteum of the skull, this is the cephal hematoma. Or below the scalp of the glial aortica, this is the subclavian hemorrhage. So this is the difference between both. Is it clear?
So one question, sir.
Yeah, this is the recall question.
So why is the subclavian hemorrhage considered as life-threatening compared to cephalohematoma?
Because this is extracranial hemorrhage and may lead to massive bleeding. So this is maybe become massive, not like cephal hematoma. So this is maybe massive hemorrhage. So that is why it is life-threatening, maybe life-threatening.
Okay, sir.
So if there's any
Thank you,
massive,
sir.
okay, thank you.
And what about the suture line? Which crosses the suture line, doctor? Cephalohematoma or subclavian hemorrhage? The suture line.
Subgaleal.
Okay. Here is about the type for forceps. What is the type of forceps? We have said before, outlet or mid cavity or the low forceps. So first we start with the Regalis forceps, this low cavity outlet forceps, and this Simpsons, and this is the mid cavity but not rotational forceps. And Killen forceps, it is the mid cavity and the only rotational forceps. And the naval pants, this is the mid cavity non-rotational forceps. So this is the both is mid cavity but non-rotational forceps, and this is the only rotational forceps is the Killen forceps. So what is about component or part of the forceps? Have four major part. This is the handle, and this is for lock, and this is the shaft of forceps, and this is a plate, left and right. Okay. Here, this is about outlet forceps and non-rotational forceps, and this is the rotational forceps we discussed before. This is outlet is Regalis forceps, and non-rotational forceps is low outlet forceps, Regalis, and mid cavity forceps, navel pulse, and rotational forceps is the Killen forceps. How to choose the instrument? There is many instrument. How to choose the instrument? So there are many different instrument, and ventouse and force delivery are associated the different risk and benefit. So to choose one of the forceps or the ventouse, so choose should be defined by an instrument must appropriate to clinical circumstance or operator level of skill. So it depends on the level of skills. And rotation delivery should be only performed by experienced operator. So rotational ventus, manual rotation and forceps, and Killen forceps. This should be done, should be performed by experienced operator. Here, this is about the risk and benefit of the ventus versus forceps. The ventus is less trauma to maternal pelvic floor, the benefit. So this is mainly for the trauma for the fetus. And the risk more likely to fail, sequential use of instrument, cephalic hematoma, and retinal hemorrhage. This is about the risk of ventus. Forceps more likely to be successful, but here is more trauma to maternal pelvic floor injury, and temporary fecal incontinence. So this is comparison between the ventus and forceps. This is how to decision to take to do the instrument, or to choose the one of the instrument. Here, this is very important to know at when we'll do the assisted vaginal birth. It is at delivery room, or in the theater, or in the delivery room. So it will depend on many factors. So first we'll discuss the position. So if you do assessment and the position less than 45 degree or rotation from occipital anterior, so this is may be suitable for operative vaginal delivery in delivery room. So if the position less than 45 degree, consider operative vaginal delivery in the theater if the position more than 45 degree or rotation from the occipital anterior. In station, this is very important, station +1 or 2 if all the other finding is favorable. So you can do operative vaginal delivery in the delivery room, because many questions came in exam as AMQ and asking how to do the operative vaginal delivery in the delivery room or in the theater, or you do cesarean section. So station here is very important. It is station +1. If station 0 or 1 +1, this is may consider operative vaginal delivery in the theater. And if above 0 station, this is for cesarean section. No role for the assisted vaginal birth. What about molding? If it's molding +1 or no molding, this is for delivery room. And if or +2, this is considered in the theaters. And +3, we said before, this is maybe a risk of the CBD, so you should reassess the patient and avoid to do operative vaginal delivery. Cabot also, or +1 for delivery room, +1 or +2, this is in the theater, and if +3, this is considered cesarean section. Also, the descent here is very important. If there is with contraction and pushing, this is for delivery room. If there is minimal, may consider operative vaginal theater, or there is no progress or no descent, so consider cesarean section. So this is about the, if there is easy rotation, can do in delivery room, or there is some rotation, maybe in the theater, or if there is no rotation, so you need to do consider cesarean section. And this is about the pelvic dimension and the fetal status. It depends on the CTG or low scalp pH. So generally, if there's confusion, look for the station. This is very important in assessment of the for patient for the operative vaginal delivery. So we said if above spine this is for cesarean section. And if 0 or +1, so delivery in OT. So the delivery should be in OT. If more than +1, so this is the +2 or plus, this is if the +2, so you should look for if this is the patient prime gravida or this is multiparous. Multiparous. If the prime gravida, you should do here in the theater. Consider operative vaginal delivery in the theater. If in multiparous, you can do here, consider a delivery room here, if 2. So prime gravida, consider operative vaginal delivery in the theater, +2. Multiparous for delivery room. So +3 or is the perineum, so delivery in the room. So this is summarized about the station related to the assisted vaginal birth. Is it clear? So if you confuse, you should just look for the station. Is it above 0 for cesarean section, 0 or +1? This is for delivery at OT. +2 here. Look for this is prime gravida or this is the multiparous. If the prime gravida, you should consider the OVD in the theater. If the multiparous, consider OVD at room. And if +3 or the perineum, regarding the parity, you should delivery at room. This is summary about how to do operative vaginal. Is it clear? So what about high failure rate? This high rate of failure associated with the maternal PMI is above 30. So this is if the PMI more than 30, this is can lead to high rate of failure. Estimated fetal weight more than 4 kilograms. So more than 4 kilograms, this is may increase the failure rate. Occipital posterior position also. Mid cavity delivery or when the fifth palpable bare abdomen. So this is about the high rate of failure associated with the assisted vaginal birth. Is there a role for ultrasound and assessment for assisted vaginal birth? So ultrasound assessment of fetal head position prior to assisted vaginal birth is recommended where uncertainty exists following clinical examination. So there is insufficient evidence to recommend the routine use of abdominal or perineal ultrasound for assessment of the station, flexion, and descent of the fetal head in the second stage of labor. So what is the type of consent? Anybody knows? What about the type of consent for assisted vaginal delivery in the room or in the trial in the theater? Is any difference?
Yes.
In the theater,
In the room, only. In the theater
written
room,
consent.
Mr. Barbie?
Verbal consent.
In delivery room, verbal consent.
Yes, in delivery room, you need just verbal consent. Oh, and the operative vaginal delivery trial in the theater, we need written consent. That is the difference. That is it. Okay. This is the difference between the trial in the room and the trial in the theater. So in the delivery room, just we need verbal consent. Here we need verbal consent in the birth room, and the written consent should be obtained for a trial of assisted vaginal birth in operating theater. So this is maybe the question. What about performing assisted vaginal birth? Assisted vaginal birth should be performed by or in the presence of operators who have the knowledge and skills and experience necessary to assess the woman, complete the procedure, and manage any complications that arise. So this is very important to be expertise in operative vaginal delivery. Advise obstetric trainees to achieve expertise in spontaneous vaginal birth prior to commencing the training in assisted vaginal birth. Ensure obstetric trainees receive appropriate training in vacuum and forceps birth, including theoretical knowledge, simulation training, and clinical training under direct supervision. Competence should be demonstrated before conducting unsupervised birth. Complex assisted vaginal birth should only be performed by experienced operators or under the direct supervision and experienced person. What about supervising assisted vaginal birth and location? So discussed before. So an experienced operators competent at mid-cavity birth should be present to supervise all attempt and rotational mid-pelvic assisted vaginal birth. Non-rotational low pelvic at lift out assisted vaginal birth have no low probability of failure, and most procedures can be conducted safely in birth room. Assisted vaginal birth having a higher risk of failure should be considered in trial to be attempted in place where immediate recourse to cesarean birth can be undertaken. What about the instrument for assisted vaginal birth? The operator should choose the instrument most appropriate to the clinical circumstance and their level of skills. Operators should be aware that the forceps and vacuum extraction are associated with the different benefits and risk. So failure to complete the birth with a single instrument is more likely with the vacuum extraction, but maternal perineal trauma is more likely with the forceps. Here, this is a vacuum extraction compared with the forceps assisted vaginal birth. This is regarding the fetal complication and maternal complication. So here we'll discuss about vacuum extraction. So it is more likely to achieve to fail as achieving vaginal birth. And as you know, forceps have high success rate than vacuum. So it's vacuum more likely to fail and more likely to associate with the cephalic hematoma, and more likely to associate with the retinal hemorrhage, and more likely to be associated with the maternal worries about the baby. And here, less likely to be associated with significant maternal, perineal, or vaginal trauma. This is associated higher with forceps. And no more likely, so is equal, associated with the birth, cesarean birth, and with low 5 minutes Apgar score. This is the same like forceps and need for photocopy. So here, the difference here in more likely to fail and cephalic hematoma and retinal hematoma, and less to affect the maternal, perineal, and vaginal trauma. This is compare between vacuum extraction and versus forceps. Okay, operator should be aware that the soft cup vacuum extractor have the higher rate of failure but a lower incidence of neonatal scalp trauma. A rotational birth should be performed by experienced operator, the choice of instrument depending on the clinical circumstance and expertise of the individual. The option include Killam rotational forceps, manual rotation followed by direct traction forceps, or vacuum or rotational vacuum extraction. So this is the important in the new guideline here about what are the, at what time you can discontinuation of the vacuum and discontinuation of the forceps. So the discontinued vacuum assisted birth where there is no evidence of progressive descent with moderate traction during each pull of the correctly applied instrument by experienced operator. So what about the complete vacuum assisted? Anybody knows? The complete vacuum assisted birth. At what time we said this is the complete vacuum assisted birth? We have 6 bull.
3 to pull the
Three
head
pulls.
to the
Three,
perineum,
I'm saying.
and if success, we can put more 3.
Yes, Dr. Sarah. Yes, we have 6. 3 first to pull the head on the perineum, and there's additional gentle pull to deliver the head out of the perineum. This is about the complete vacuum assisted birth. So here the complete vacuum assisted birth in the majority of the cases with the maximum 3 pull. So the first one is the 3 pull to bring the fetal head on the perineum. So this is the maximum to do 3 pull to bring the fetal head on the perineum. And if the head become in the perineum, so you need 3 additional gentle pulls to deliver the head out of the perineum. So this is about 6 pull. This is about complete vacuum assisted birth. If there's a minimum descent with the first 2 pulls of vacuum, the operator should consider whether the application is suboptimal, the fetal position has been incorrectly diagnosed, or there is cephaloperipheral disproportion. So we said to complete you do 3. If you do about the first 2 pull of the vacuum and there is minimum descent, you should look for what is the causes of the minimal descent. Maybe they're not applied correctly, or this optimal, or the fetal position has been incorrectly diagnosis, or there is cephaloperipheral disproportion. Maybe this molding plus 3. In less experience, operator should stop and seek a second opinion. This is very important. If you less experienced operators, you after 2 pulls, you should stop and revise and then seek for second opinion. If there's experience, operator should re-evaluate the clinical finding, either change approach of or discontinue the procedure. So here the difference between the less experienced and the experienced operator. So if you have less experience, you should seek for second opinion. If you give your question in the AMQ and give you scenario about the minimal descent after 2 pulls, look for this if less experience or this experience operator. So it's here different, because if less experience, you should stop the proceeds and seek for the second opinion. If you have experience, you should reevaluate the cases, evaluate the clinical finding, so either to change the approach or to discontinue the procedure. This is about the important discontinuation of the vacuum assisted birth and its management. Is it clear? So I will summarize it again. Complete vacuum assisted birth, it is have 3 pull maximum to bring the fetal head to the perineum, and there's three additional gentle pulse used to deliver the head out of the perineum. If you have less experience after 2 pulse, you should seek for the second opinion of her experienced operator should reevaluate the clinical file. This is about how to deal with the vacuum assisted birth. Is it clear? And discontinue of vacuum assisted birth if there have been 2 pop off of the instrument. So if you have 2 pop off of the instrument, you should stop. So if you have less experienced operator, you should seek the senior 5. So you need senior support after 1 pop off. If you had the best chance of a successful assisted vaginal birth.
Excuse me, sir, what do you mean by pop-off? Pop-off means detachment of an instrument?
Please wait your mic.
Detachment of instrument, pop-off mean?
Okay, is it clear? So you discontinue the vacuum assisted if they have 2 pop off. If you have less experience, you have only 1 chance, 1 pop off to ensure the woman is the best. So you should seek the senior advice.
Hello, doctor. I want to ask, what do you mean by pop-off? Pop-off mean detachment of instrument?
Yes, yes. So it is 2, you should stop the instrument. If you have less experience, you need 1 pop off to seek the senior advice.
Right. Thank you.
What about the sequential instrument? Is this any role of sequential instrument? So the use of sequential instrument is associated with the increased risk of trauma to the infant. So, however, the operator needs to balance the risk of the cesarean section birth following failed vacuum extraction with the risk of forceps birth following the failed vacuum extraction. So this is the question. Okay. Obstetrician should be aware of the increased neonatal morbidity following failed vacuum assisted birth and or sequential use of instrument, and should inform the neurologist when this is required to ensure appropriate care of the baby. So, sequential instrument, so increased trauma to the infant. So the use of sequential instrument, especially ventouse followed by forceps, has been associated with severe scalp trauma and intracranial hemorrhage and even neonatal death. So that is why we should do discuss about sequential instruments, because we have high risk to the infant. So if you do ventouse followed by forceps, you should anticipate this complication, maybe have severe scalp trauma or intracranial hemorrhage or neonatal death.
Doctor, do you mean by sequential instrument that we from ventouse to forceps, we use both of them?
Yes, Dr. Ayman. Yes, if you use the ventouse and failed, then you use the forceps. This is sequential instrument. So maybe use ventouse followed by forceps, because we said ventouse have high failure rate. So if you do ventouse and then the forceps, this may lead to a problem to the trauma to the infant.
Thank you.
So no
Welcome.
sequential instrument usage.
Balance risk of the second instrument, potentially difficult second stage cesarean section. So this should be compared between the to do sequential instrument versus difficult second stage lower cesarean section. So the second instrument, consider if the head low in the pelvis. So if you can use the low outlet forceps. If you have the position is no, this is anterior posterior. No divine evidence of CBD, cephalopelvic disproportion. Appropriately experienced operator. So you can do sequential instrument if you have experience of the position is known and the head is low, and if this is in consider if regard the cesarean section. And the second stage, lower cesarean section, consider if there's the highest head. If there's high head or the position is not known, or there's excessive caput and molding, and appropriately experienced operator. So you should compare. You want to do sequential instrument or cesarean section. It depends on the condition. So this is when you consider the second instrument and when to consider the lower cesarean section. So discontinuation of attempt forceps and its management. Discontinued attempt forceps pairs where the forceps cannot be applied easily, and the hand do not approximate easily, or if there is a lack of progressive descent with the moderate traction. So it is very important to apply it easily. Discontinue rotational forceps best if the rotation is not easily achieved with the gentle traction. If you fail to do the rotation by gentle traction, is not easily, should discontinue rotational forceps. So discontinue attempt forceps pairs if the birth is not imminent following 3 pull of the correctly applied instrument by experienced operator. So you should stop or discontinue the forceps if you have 3 pulls. If you have 3 pulls, you should discontinue the forceps. This is about forceps. If there is minimal descent with first 1 or 2 pulls of the forceps, the operator should consider whether the application is suboptimal, the position has been incorrectly diagnosed, or there is cephalopelvic disproportion. This is the same like vacuum, which is after 2, and here is after 1 or the 2 pulls as forceps. Less experienced operator should stop and seek second opinion, and experienced operator should be reevaluated. This is the same as vacuums, reevaluate the clinical file. So there is the rule for episiotomy. So what about the role of episiotomy in preventing maternal pelvic floor morbidity? So mediolateral episiotomy should be discussed with the woman as a part of preparation for assisted vaginal birth. When performing lateral episiotomy shoulder, Dr. Asma, please with your mic. When performing a mediolateral episiotomy, the cut should be at the 60-degree angle initiated when the head is distended to perineum. This is very important because this is, we'll discuss this later in the perineal tear. So you should do mediolateral episiotomy. Should be the angle is 60-degree angle. So this is, we'll discuss it later in perineal tear. In the absence of robust evidence to support either routine or restrictive use of episiotomy as assisted vaginal birth, the decision should be tolerated to the circumstance at the end as the preference of the woman. So woman wishes here is very important, and the evidence to support the use of mediolateral episiotomy as assisted vaginal birth in terms of preventing oocysts is stronger for nulliparous women and for birth via forceps. So what about the prophylactic antibiotic and thrombophylactis? A single prophylactic dose of intravenous amoxicillin and linoleic acids should be recommended following assisted vaginal birth. Good standard of hygiene and aseptic technique are recommended. Reassess women after assisted vaginal birth for venous thromboembolism risk and the need for thromboprophylaxis. So what about the analgesia? We'll discuss analgesia before birth, and then we'll discuss analgesia after birth. In the absence of contraindication, women should be offered regular non-steroidal anti-inflammatory drugs as paracetamol routine. Precaution for care and the bladder after birth. So how to care the bladder? The timing and volume of the first void urine should be monitored and documented. So this is very important to look for the first void urines after operative vaginal delivery. Over women, physiotherapy directed strategies to reduce the risk of urinary incontinence at 3 months. And women should be educated about the risk of urinary retention so that they are aware of the inappropriate importance of bladder emptying in the postpartum period. So here is very important to care of the bladder after birth. So looking for this any urinary retention or not. A post-void residual should be measured if the urinary retention is suspected. I recommend that women who have received regional analgesia for a trial of assisted vaginal birth in the theater, you have indwelling catheter in situ after the birth to prevent the covered urinary retention. This should be removed according to the local protocol. Reducing the psychological morbidity for women. How to reduce the psychological morbidity? Shared decision making, a good and the good communication, and positive continuous support during labor and birth have a potential to reduce psychological morbidity following the birth. Review women before hospital discharge to discuss the indication of assisted vaginal birth, management of any complication, and advice for future births. Best practice is the way the woman is reviewed by the obstetrician who performed the procedure. So it should be revised and examined by the obstetrician who performed the procedure. Over advice and support to women who have traumatic births and wish to talk about their experience. The effect on the birth partner should be considered. Do not over a single session. High intensity psychological intervention is the focus on the relieving trauma. Over women with the persistent post-traumatic stress disorder symptom at 1 month, refer to a skilled professional as per the NICE guidance or the post-traumatic stress disorder. What about the information for the future birth? Inform women that there is a higher probability of spontaneous vaginal birth in subsequent labor following assisted vaginal birth. Individualized care for women who have sustained a third or fourth degree perineal tear or with ongoing pelvic floor morbidity. This is discuss about the future birth. And finally, discuss the governance issue. Record blood sample should be received and recorded following all attempts at the assisted vaginal birth. Adverse outcome included unsuccessful assisted vaginal birth, major 5 obstetric hemorrhage, shoulder dystocia, and significant neonatal complication should be triggered and incidence report as a part of effective risk of management process. What about the documentation? The documentation for assisted vaginal birth should include detailed information on the assessment, the decision making, and the conduct of the procedure, and a plan for the postnatal care, and sufficient information for counseling in relation to subsequent pregnancy. So use of the standardized performa is recommended. This is about safety criteria for operative vaginal birth. So first, select optimal place for birth. you should continue. So first, select optimal place for birth. So continue in the labor room if the head is low. We said if there's +3 or is the perineum, and there is no rotation or rotation easily, and no feature of cephalopelvic disproportion. So this is in labor. Consider trial in the theater if the head fifth palpable abdominal and the head is mid cavity +1 or +2 or 0 station. Rotation is square and the feature suspicious of CBD. Select optimal instrument. So select instrument most competent at using, and select instrument least likely to fail, avoiding sequential use of instrument, avoid vacuum assisted birth at less than 32 weeks of gestation, and use discretion in 32 to 36 weeks of gestation. Correction application of the instrument. If unable to achieve correct application, if failed to do the correct application, so you should reassess engagement, position and station and synchronicity. So this is very important to assess the patient. Seek for a second opinion if you have the less experience. We said if you one bob off in vacuum and 1 or 2 failed pull in forceps, for the less experience, you should seek for the second opinion. So the experienced operator should be assessed, re-evaluate the clinical condition, may change the instrument or discontinue to proceed. So discontinue proceed if not achieve correct application with above measure. Attempt rotation if indicated. If unable to achieve rotation easily, so senior obstetrician to check to correct application and to correct rotation technique. So seek for the senior advice. Discontinue proceeds if the rotation is not achieved with the above measure.
Dr. Fatah, regarding the select optimal instruments about avoiding vacuum, is it the limit 32 or 34 week?
Dr. Ayman, is regarding the use of the vacuum, you should avoid here. You should avoid the vacuum if the gestation is less than 32 weeks of gestation, and can use the vacuum with caution if the gestation is between 32 to 36 weeks. This is about optimal instrument.
Thank you.
Okay, welcome. Here is attempt attraction and reassess after 3 pulls. So consider discontinue the procedure if the vacuum assisted birth, the head is not on the pelvic floor. This is very important. So the head is not on perineum, and the birth anticipated with the maximum 3 gentle pull to ease over perineum. So we said before the vacuum should be discontinue if there's 3 pull maximum to bring the fetal head to the perineum. If the forceps pairs and the head is not crowning with the pairs imminent. If you do forceps and the head is not crowning, you should stop the procedure. Failed attempt at operative vaginal pairs. Consider the consequence of the failed attempt at operative vaginal pairs. Consider forceps following by failed vacuum only with the vertex at low station. Increase risk of trauma to the fetus and oocytes with sequential instrument use, or increase morbidity for mothers with the cesarean pairs in the second stage. So you should use the second sequential instrument or use the second lower segment cesarean section. Increased risk of the fetal head impacts at cesarean section. So this is about the safety criteria for operative vaginal delivery. So now we finish the first guideline. After the question, we'll discuss the second, the two guidelines. It is shoulder dystocia and the management of the third and fourth perineal tear. So this is the question one. Who will share with us?
Shall I?
No.
Can I share?
Yes, yes, sure.
Which of the following condition can permit the use of either forceps or ventouse and not forceps exclusively? After coming head of breech, face presentation, occipito-posterior position, prematurity less than 34, and suspected coagulopathy in the fetus. Permit the use of either forceps or ventouse, not forceps exclusively.
Yes.
After coming head of the breech both can use face presentation forceps, not ventouse.
Yeah, we talk mainly about the rotational. Yeah, about you can use rotational either forceps or the ventouse. So what was your answer?
Occipito-posterior position.
Yes, excellent. You are C, because we use for rotational, we can use the forceps and the ventouse. So here we can use the forceps and ventouse. The same for the occipito-posterior. So occipito-posterior position. So it is C. Okay, occipito-posterior position. The next question.
A woman attends the antenatal clinic at 36 weeks of gestation. It is her first baby and she wants to know if she will have an episiotomy and what are the potential benefits compared with the second degree tear. What is the benefit of mediolateral episiotomy? It may decrease the incidence of anterior perineal tear during instrumental delivery. It may decrease the incidence of healing complication during instrumental delivery. It may decrease the incidence of labial trauma during instrumental. It may decrease the incidence of postpartum hemorrhage during. It may decrease the incidence of third degree perineal trauma during instrumental delivery.
Before mediolateral episiotomy.
It may decrease the incidence of third
Yes,
degree
E.
perineal trauma.
Yes, it's
Yes.
about
Sir,
6
it's
days.
E.
E, yes. Yes, E. You're right.
E, sir.
Agree with E?
Yes, sir, E.
Okay, thank you. So it is E. It may reduce the incidence of the third degree perineal trauma during
Yes, we
instrumental.
agree.
Okay, thank you, thank you. Any volunteer for the next question? Who will share?
Yes, Dr. Fahd, hi, I can read it. It's okay?
Sure, Dr. Sima.
Dr. Fahd?
Welcome. Yes, welcome, Dr. Sima.
Yeah, okay. Yeah, thank you. So, mashallah, you're very clever. You recognize my voice. Thank you.
Yeah,
Okay. you in Arabic it's Zaki. Yeah, Zaki,
Yeah.
intelligent. Zaki.
Yes,
Yeah. Okay, so the next question: for each of the following childbirth related complication, choose the single most likely method of delivery or maneuver associated with that complication.
So we'll see the
Okay,
question.
so the question, yeah.
Subclavian hematoma. Citric analysis injuries.
Subclavian hematoma, obstetrical sphincter, and then reversion to malposition.
Okay. So
The
answer correct.
subglial hematoma, doctor. Yeah, the number 3 is more with one vacuum.
It is mainly the vacuum. Yes, you are right. This is the non-complication.
Subglial hematoma is more common with ventouse.
Yes, excellent.
Yeah.
Should be
Yes, more common with ventouse delivery.
yes, ventouse delivery. So
Ventouse.
the answer,
Yeah,
the
it will
correct
be
answer.
ventouse.
Ventouse.
L. Option L, doctor. Yes, option L.
Okay, okay.
Ventouse delivery. Right.
Question 4.
And then the next one.
So this.
The next one, can I, doctor, again to see the, yeah, thank you. Obstetrical anal sphincter, it is with the rotational forceps is more common complication.
Yes, yes, you are right. Exactly. So associated with the forceps and mainly with the rotational.
F, option F, doctor. Yeah.
Yes, you are right. The rotational forceps is associated with the
rotational forceps.
perineal tear.
Yeah.
And
Yes,
finally,
that's right.
5.
And the third one, doctor, reversion to malposition. Reversion to malposition, it is more common with, I think it's again reversion to malposition. Maybe it's again that
Sir, it's D. Manual rotation of the fetal head.
The
Reversion.
I am thinking between
manual rotation.
manual
D. It's D.
D, doctor, D.
Or
Manual
D.
rotation of the fetal head. D.
Yes, you
Yes. D.
agree with D?
Yeah, D, doctor.
Yes,
Yes.
sir, D.
Yes, I think D. Okay. Yeah, D.
Agree
Manual
with D?
rotation, it's more
Yes,
reverse.
sir, D.
Dr.
D
Fad,
or D?
Yeah.
Welcome.
I have a question, Dr. Fad.
Yes.
Isn't the oasis common in occipital posterior position?
Oasis.
The anal sphincter injury,
Rotational forceps.
or not occipital posterior?
Maybe associated with occipital posterior. If you did rotational forceps. So occipital posterior, you need to do rotation. So if you do rotation, this may lead to oasis. Okay.
Sorry to intrude, sir, but in rotational forceps, there is an increased incidence of obstetric anal sphincter injury.
Yes.
More in rotational forceps, if I'm not wrong.
Yes. So the answer of 3 is the ventouse delivery. Answer for rotational forceps. The manual rotation of the fetal head. Thank you, Dr. Sima. Thank you.
Yeah. Thank you very much, Dr. Fad. Thank you.
Welcome, Dr. Sami. You are welcome. Who will share? Question 6.
Doctor, if there is no volunteer, I am ready. You see if there are other friends or volunteer.
You are welcome, Dr. Sima.
So,
Shall I, doctor?
So shall I continue or? Oh, okay.
Shall I,
I think there is one Dr. Shiva. Yeah.
Okay. The question is question 6. Dr. Sima.
Doctor, I will read.
Oh, shall I read, doctor? Oh, I read. Oh, okay.
Who will read?
Okay, she will read.
problem.
She will. Okay.
Okay.
I read or she read. I don't know. I am ready. Whatever you decide.
Dr. Parveen?
Dr. Sima, I will read.
Yeah, okay. Okay, Dr. Parveen.
Question. Yeah, doctor.
Yeah,
Question 6. A 30-year-old woman in her second pregnancy at 40 weeks gestation has progressed well in labor and has been effectively pushing for last 90 minutes. She was fully dilated 2.5 hours ago. There is no palpable head on abdominal examination. Vaginal examination shows that the vertex to be occipito anterior position and 2 cm below the ischial spine. There is 3+ caput and no molding. The CTG is showing late deceleration. Her first baby was delivered by spontaneous vaginal delivery. Second, है ना? 2.5. No, 5. With 2.5.
Late deceleration. Late deceleration.
So it is ventouse or forceps.
Doctor, can I see the question one?
Sir, if sir, how about eye fetal blood sampling?
Caput 2 or 3 plus, no, we cannot do fetal blood sampling.
Okay.
Late
Caput
deceleration.
That's okay. Okay.
Yes. Late
I said
deceleration.
forceps.
It is 2 centimeter
Forceps.
below the skull spine. Okay, it is fine. It's okay.
Forceps non-rotational. Okay.
Yes.
That's forceps
Yes.
delivery.
Excellent. Yes.
Forceps, yes, non-rotational. Yeah.
It's not rotational. So forceps is not rotational. So this is the answer is D.
What about 3 plus caput? Can we apply forceps on 3 plus caput, sir, please?
Sorry.
Forceps can be applied.
For forceps we can. For ventouse we cannot. If there is a molding and caput.
This is the D.
Yes,
Green
you
is
are
D.
right. If there is molding, we can use forceps. Not
There is plus 3 of caput. You can
Yes,
consider.
but not
Plus
ventouse.
caput and head is low. You
Yes,
can
you
use.
should. Yes. Okay, Dr. Hassan. Yes, you should avoid the vacuum. You can use the forceps. Okay.
Okay.
The next question. So the answer is forceps rotational.
Okay.
So question 7 and 8.
Okay. 7. A 42-year-old gravida 1 para 0 is seen on the labor ward round. Labor has been progressed well and she has been fully dilated for 2 hours and pushing for last 1 hour. There is no palpable head on abdominal examination. Vaginal examination show vertex to be in left occipital anterior position and 1 centimeter below the ischial spine. There is 1 plus caput and no molding. CTG is normal. She has conceived by IVF after trying for 6 years. For last 1 hour. She has been pushing for last 1 hour.
Have fully dilated for 2 hours. And pushing
2
for
hours and
the last 1 hour. No palpable head on the abdominal examination. Vaginal examination show vertex the occipital anterior position and 1 centimeter below the ischial spine. There is plus 1 caput and no molding. CTG is normal. Is conceived by IVF after trying for 6 years.
6 years. She has been pushing for
1 hour.
But she's fully for 2 hours.
You can give her chance.
Yes,
Can you
doctor.
please show the options?
Allow pushing for further 1 hour.
Yes, you can give her. You can give her chance for.
Maybe we can
sometime because her.
We'll see.
Sir,
The question again.
Sir, how about D, forceps non-rotational?
Sorry?
Yes, about.
CTG is good and still she had time.
Yes, CTG is normal. Yes,
normal.
Good. And only plus 1 caput.
Prime, she had 3 hours. 1 passive and 2 active.
Occipital posterior.
Doctor, she's fully dilated and then she's pushing for 1 hour. This is total of 3 hours now.
But Prime, she had total 3 hours. 1 passive and 2 active. If she finished 1 hour, still she had 1 hour of CTG good.
For 2 hours, and she's pushing for 1 hour. This is 3.
Yes, we have the next 1 hour. So it will be totally 3 hours.
She had 2 hour active phase. Prime, she's not libra.
This is the primary evidence. You need pushing for 1 hour to give her chance.
Okay,
Agree?
it is 3. Yes.
3 hours
yes,
are over.
3 hour total, 2 active, 1 passive.
Yes, the question is H. The answer is H. What about the question H?
You are asked The question 8, you have asked
So
to
what
see
is the
a
best
20
answer?
Yes, to allow. Okay.
To allow.
To allow 1 hour pushing.
Yeah, it's allow pushing for further 1 hour. So give her chance for pushing for 1 hour. Complete.
Total 4 hours.
Okay. Yes, because CTG also is normal.
It is normal. Yes, you are right. And only plus 1
Yeah,
cabots,
CTG okay.
primary gravidal. So the question is,
If mentioned,
Question is,
exhausted.
you have called to see a 22-year-old gravida 2 para 1 who has not delivered after 1 hour of active pushing. On vaginal examination, the fetal mouth, nose, and orbital ridge can be easily felt. The chin of the fetus can also be felt, and it is pointing towards the symphysis pubis of the mother. The presenting part is about 2 cm below the ischial spine. The CTG is satisfactory. Mouth and orbital. So this is row presentation, no, doctor? Orbital ridge.
it's gravida 2 para 1.
Yes, it's bro presentation. That's right. So she needs
Bro and she is anterior, yeah, doctor?
Yes.
Bro and
so she needs cesarean.
no. If it is posterior, then she cannot deliver.
No,
So,
bro always
Mento.
cesarean. Bro
This is meant to
presentation is
anterior.
always cesarean.
Mento anterior can deliver.
If
Please
brow
mention
cesarean,
that.
meant to anterior, she can deliver normal. Meant to posterior, cesarean.
We can allow
Anterior deliver, posterior needs cesarean. This
So
is what I know.
It is face presentation.
further 1 hour.
Face presentation, meant to
Yes,
anterior for normal.
you are confusing with face. Yes,
it is face presentation.
for face, not
If
for
meant to
bro.
posterior for cesarean, meant to
That's
anterior
for
for
face.
normal. Brow for cesarean.
It is
It is this.
Bro always
so
is cesarean. Yes, bro presentation is
plus
always
2
cesarean.
centimeter. So it is plus 2. So can use the
Forceps.
low mid cavity.
yeah,
Yes, low assisted vaginal pierce. Because
But it will be face, Dr.
that's
Fatih,
hard
or what? Face presentation, this one, Dr. Fatih?
to of the fetus
This is
can be
face, doctor. Face presentation,
Mouth,
mental
nose,
anterior,
Yes, face
or
presentation.
yes,
Face
yes,
Yes,
presentation.
face.
yes.
Below 2 centimeter below ischial spine.
I thought is bro. Okay, I thought it's bro presentation. Okay, so it's
Yes.
face.
Yes,
Face
maybe.
presentation, she can deliver.
nose and that's
there's
right
no
because it's
for-
mentum anterior. Yes, mentum anterior. Yeah.
we can use forceps, doctor.
You can use
But why,
forceps.
Yes, forceps.
Yes.
but why we
That's
will
right.
use the forceps? It's
Rotation.
1 hour pushing only.
Yes, you can use non-rotational
Because she's
forceps.
multipra. She's
Yes.
multipra. She had only 1 hour inactive.
You
So
are
she
right.
finished her time.
Yes, you are right. Yeah. So the answer will be this is the question.
Forceps
Yes, forceps.
to help
is
her. Yeah.
non-rotational.
Okay.
So
But
Sir, I
meant
have
to posterior, Dr. Fatih, she cesarean, right?
Non-rotational.
yes, yes.
so
Non-rotational.
for forceps
Forceps.
non-rotation.
Sorry?
For forceps non-rotation. D. T is D. Agree with D?
Agree with?
D.
Yes,
Yes,
agree
agree
with
with
D?
D.
Yes, yes.
Yes, so forceps,
Yes,
not
yes.
rotation.
Yes.
Yes, we
Non-rotation.
agree.
Yes.
Yes,
Yes.
we agree.
Yes, agree. Agree.
Yes, Amam.
Sir, I have a
That's
question.
right. Yes, yes,
Uh,
yes.
for active pushing for primary, how much we should wait? Because the first question was the active pushing for primary. After
Primary
1
delivery,
hour,
we have the second stage where you should be delivered in 3 hours.
3 hours.
One passive hour, one active, one passive, and 2 for active.
2 for
So,
active. Okay.
Okay.
Yeah.
1 and 2. Okay,
For
that
primary
is
delivery.
important point. Very important. Okay.
So 2 active pushing for
Okay.
primary gravida. Okay, thank you. Thank you so much.
Yes,
What
that's
about
very
Aneurysm
important.
inhibition is the middle
Okay.
of the active phase.
This is the last 2
What-
questions. Okay.
What about the multiple multi-paras, Dr. Fatih.
It is 2 hours.
2 in
One passive
total.
and one active. Yes, it should be delivered in 2 hours.
Okay.
One passive and one
2
for
hours.
active.
Okay.
Thank you.
Okay.
Very
The last
important.
question.
Thank you.
Yes,
Very
yes,
important.
this Interpartum Kernas guideline is very, very important because a lot of the question depend on
Very important.
about.
Yeah,
Yes, very
yeah,
important guideline.
Very
Really.
important.
Yeah. Okay, question 9. Okay. Who will
Question
share?
9.
Yes.
Should I? Or no? Hello?
Okay, question 9.
I will read, doctor.
Yeah, if
I
you are
cannot see the
welcome.
question. Yes,
Dr. Barzin.
yes, doctor. A 24-year-old gravida 3 para 2 with previous 1 cesarean section followed by successful vaginal delivery is seen in the labor ward at second stage of labor. She is 41 weeks pregnant and her labor has been progressed well in first stage up to 8 centimeter. Subsequently, it took her 5 hours to progress from 8 centimeter to fully dilated. She has been pushing effectively for 1 hour. On examination, there is fifth of her fetal head palpable abdominally. On vaginal examination, the vertex is occipito-transverse position with 2 plus of caput and reducible molding. The vertex is at the level of ischial spine and CTG is set at the level of ischial spine.
The vaginal examination is occipito-transverse position with plus 2 and residual molding. So, what is your decision? Which is the option?
Cesarean better.
Cesarean section.
The cesarean section. Deep transverse
Why not
C-section.
rotational forceps?
Cesarean.
Why not for rotational forceps?
No, because the head is at the spine, they said, no, doctor.
Is it grade 1 or grade 2?
Exactly, the head is high.
For cesarean section, what is the classification? The grade 1 or grade 2? It's grade 2, yes. Yes,
Grade 2 cesarean section.
Yes, it is. So it
Said option B,
is normal,
cesarean
grade 2
section,
cesarean
grade 2.
section.
Cesarean section, grade 2.
Cesarean section, grade 2.
Grade 2.
So it's transverse arrest and a patient is going into obstructed labor, so cesarean section grade 2. Option B. That's right.
Yes, you're right.
Yeah, and she's multiparous. Previous cesarean also risk
correct.
patient. I cannot wait more than this.
Yes.
Yes, we cannot so much wait. Yeah.
Risk
Last
patient.
Last question. A 34-year, question 10, a 34-year-old gravida 2 para 1 is in second stage of labor. She is 33 weeks plus 4 weeks of gestation. On examination, the vertex is at +1 and left occipito-transverse position. CTG is abnormal.
So this is paras ladies in second stage.
+1.
3 plus
Cesarean section.
Grade 1.
Occipito-transverse position.
Grade 1 cesarean section.
CTG is abnormal. +1.
Cesarean section.
I cannot do manual rotation of the head because preterm.
Because
preterm. Preterm, I can do manual rotation.
So it is the option.
She is abnormal and she's
Yes, all right.
CTG abnormal.
Yes, you can do manual rotation.
Yeah, preterm.
But manual rotation with the forceps or with the ventouse. If you do manual rotation, then you can do ventouse or forceps.
Forceps.
The gestational age.
Less than 30.
Considering the gestational age, can we go for forceps?
You are right, because we give the gestational age 33, so it's better to choose the forceps. Yes.
Forceps is more, yes, safer.
So here,
safer for her gestation. Yeah.
And the rotation is forceps.
With forceps, yes, correct.
So,
agree. And forceps.
So you think that, since she's in preterm labor, we can not go for a ventouse and we should opt for manual rotation and then apply forceps. So this is the right answer.
Yes.
Yeah. Among your rotation is with preterm. You can do it by your
Okay,
hand.
okay. All right. Okay.
This is
Because
the
it's
last
preterm.
question.
Okay. Yes, manual rotation and forceps. So option J, yes, the correct
Yes.
answer. Manual
Yeah.
rotation
Manual
and
rotation with the
forceps.
forceps.
Okay.
You should choose the forceps with manual rotation.
With the
So
forceps.
this is
Okay.
yes.
Mhm,
So that is
mhm, yes.
all about the assisted vaginal birth. So we'll need to discuss the shoulder dysocial and the prenatal. So we can postpone for the next weeks, or we'll continue. I think it's better to
Okay.
Sir, please
postpone
explain
this
the
if
question number
possible.
2, sir.
If possible.
Sir, question number 2, please.
Question number?
Rotation forces.
2, sir.
Question number? Question 2?
Yes, sir. Second question. I didn't understand the answer for it.
This is the question 10 or 9?
Second question.
Yes.
What is the second?
Second question.
This is question, Dr. Baglo? You mean this question?
No,
She has been
sir.
pushing it.
Second question number. First, sir. Second question.
Number 2, she is asking.
Number 2?
Number 2, doctor. Number 2. Number 2.
Okay.
Number 2 question.
Okay. Yes, this question too. It is regarding the mediolateral episiotomy.
Mm-hmm. Yes.
Okay.
Yes. Yeah.
Yes, sir. I missed this question. Thank you, sir. I will go through it.
Is it okay?
Your voice is not very clear, doctor.
Yes.
Not
Yes.
Dr. Fad, your voice is very good. The lady doctor, she's asking questions. We don't
Yes,
hear
yes.
her properly.
Didn't hurt him. Yes. Okay.
Yeah.
So this is today about the session today. Inshallah, the Thursday we'll discuss.
Assalamu alaikum.
Alaikum assalam.
Yeah, Dr.
Yes, sir.
Usma here. I just wanted to discuss with you
Okay,
the
Dr. Isma. Yes,
question
you're
number
right.
10.
Question number 10.
Yeah,
Last question.
last question.
Yeah. So this is the last question.
Yeah, it says that a 34-year-old G2P1 is in second stage of labor and she is 33 plus 4 weeks. On examination, the vertex is at +1 and left occipital transverse. And CTG is abnormal. So,
Yes.
see, the first thing that will strike to me, if I have to answer, is thinking of CTG is abnormal and the head being at +1 and she being a preterm. I would just go for a cesarean section. Immediately, my mind will go to that. How could we think in your line, your line of thought?
Here the patient have T10. It's a 33 plus 4 week of gestation. And the vertex is +1. You can do patient is fully dilated, and the second stage you can do manually, no problem. You can do
And she's multivorous.
Yes,
Multivorous, her delivery can be easy if you
How
correct the
long?
position.
How? See, since the time of the abnormality of CTG is not given, how
to
long
do
can we wait?
for forceps or to do cesarean section. Here you should compare between it. So if you better to do the forceps if possible.
Mm-hmm.
So
Okay.
because the vertex are +1, and this
So you go for a manual rotation and forceps.
Yes.
Yeah.
If you
Okay.
is the
So if
manual
the
rotation
time,
and then do forceps.
yeah, if the CTG is abnormal, if they give for more than half an hour or something like that, then you go immediately for cesarean?
Yeah, it depends on the option. If you give fetal plus sampling, you can choose the fetal plus sample. If you give
Scenario, the option.
yes, it depends on the scenario and the option.
Yeah, and you will try this one. If fail, you can go for cesarean.
Yes.
Yeah, thank you very much. But I think intrapartum care is a very tough subject, and especially the one which is practiced in UK. You have
The key
to
of
be
the exam, really.
extremely
It's the key of
careful
the
and
exam. You should know
In last
by
paper,
heart
maybe we had 8
intrapartum
questions about
care.
labor.
This
Yeah.
is very important topics, really.
very important, and I
Very
think
important,
it's
yeah.
a very tough subject which you have made it very easy for us. But
Exactly.
I think it's
Thank
a
you.
very tough subject, and
Thank
I think
you
if you
very much. Yeah.
Thank you.
we
Thank
can
you.
Dr. Fatih, thank
answer
you a lot.
we can answer 3 to 4 questions. Yeah, always in the
Thank
exam.
you.
It's my
Yeah.
pleasure.
Thank
In
you very
last
much,
paper,
Dr.
wallahi, we had 8 questions in labor and delivery.
Okay.
Yeah,
Thank you
that's it.
so much.
That's it. That's exactly
Yeah,
what
so
I
yeah.
said. There are so many questions, and intrapartum care is so tricky, and
In
it's
2
so
paper,
different.
5 and 5 maybe.
No, it is so
Yeah.
different. It is so different from what we practice in our country. So we have to be very familiar with their way of practice. So if their way of practice, and that's what Dr. Fatih is trying to tell us. See, this is their way of practice, and you
That's
have
right.
to learn
That's
their way
right.
of practice.
That's
Thank
right.
you, Dr.
Exactly.
Fatih. Thank you a lot.
Thank you.
Thank
Thank
you.
you
Yes.
very
Thank
much.
You
you very
make our
much,
life
Dr. Fat.
easy.
God
Thank you.
bless you,
Thank you.
doctor. Allah
Thank you.
Thank you a lot.
blessings.
Thank you.
My pleasure. Thank you so much. Thank you. Good night.
See you in the next week, doctor, inshallah.
Inshallah.
Thank
See
you,
you.
Dr. Fat.
Thank you.
Thank
Thank
you.
you.
Thank you. Thank you.
Jazakallah khair, doctor. You are doing so much of service to everybody.
Yeah,
Thank you very
welcome,
much.
Yeah,
Dr.
wallah.
Uzma, thank you.